Actually, this is a video presentation, no theory in it. So this is just like a real life surgery. The patient details, it's a 40-year-old male patient, manual labor. He had a chronic cuff tear. He's an young guy. It's a short person also. This is a position. I do it in B chair position. That's the draping we are going to do. The hypotensive anesthesia. I always tell my anesthetist, half of the surgery is done by the anesthetist, not by me. So you have to have your this thing. So since we thought of recording it, we had the marking done. Same thing we have shown in the other video also. We have the acromion, the coracoid, the humeral head, the scapula spine. Then you feel the humeral head. Since this is already a so in shoulder arthroscopy, most of the things are preoperatively decided. We go with a standard tip in the mind. So we go in, put the trocar, you put the scope in. That's in, and try to keep your always your inflow on one side and your suction on the other side always. Accidentally, otherwise you will change in all. Or on all cases. This is then you have this thing. So this is the once you are in. This is the diagnostic scopy. This is a diagnostic scopy of the patient. This patient had a chronic tear. You can see there is no biceps. Their biceps is already torn. There is the then we were looking. It's actually a totally real live. I have not edited much. So I was looking where is the biceps. Then I came down, I saw this. So I was looking around where is the biceps tendon. Then I saw there is a cuff tear. You can see that's a cuff tear there. Then the subscap. Then once there is a cuff tear, I go mark with the, put a needle. Then I don't use a cannula. So I always prepare it glenohumerally. The cuff tissue is a little bit frayed, so so that frayed tissues we just cauterize with the RF. It's actually in 2x speed, so it will go a little faster than normal. So all the tissues you have to, because we are using the passer, it can get caught. So I am lifting the cuff in order to see whether there is anywhere biceps is seen. I couldn't find out the biceps. Biceps have already gone down. So the cuff tissue required pretty okay for a chronic cuff tear in a young patient. This is I always prepare my footprint. I use a RF. There was some kind of little erosion out there. So I go in completely, come till the back. So doing this glenohumerally initially itself gives you a good picture and an easy access when you go subacromally later on. So this is easy to prepare. This is the footprint up to the lateral cortex. So I prepare till there initially. So that's prepared. Then we use a burr to burr the footprint area. So the burr will come in. It's a larger burr. So that entire area is burred. When you are burring a female old patient, you should be really careful. Don't take too much. After that, the anger may not be holding. So since I don't use cannulas and I don't use pump, so I have to widen a little bit more my portal. So whenever you are using the burr, don't put the suction on fully. You should be in little bit in a small suction, so that otherwise the soft tissue will keep on coming onto it. And always keep it down. So you are burring, you are preparing your footprint. So it's always easier to do this kind of a work glenohumerally rather than subacromally, so that the entire area will be clean. So now I am shifting on to the acromial part. So I think I have shifted. Yeah, that's in the acromial view. You can see since it is a chronic tear, there is a lot of changes in the acromion. This is actually the acromion. If you see this kind of a mustache coming from the acromion, that means it's a chronic tear. There has been some kind of an impingement going on. So again, you are clearing all the tissues for your better visualization and for your graph mobilization. So rotator cuff tear, in chronic cases especially, most of your time is consumed in preparing for your anchor placement and preparing your cuff. So I am doing the subacromial place. This is the cuff underneath, and that is the acromion on the top. So you have to use RF. So you can use shaver if you had a good anesthetist. See, I am using the RF. I am clearing the tissue. You can see the acromion nicely, and I clear the acromion also. Prepare the acromion also. I want to see the anterior edge of the acromion, the posterior edge of the acromion, and the lateral edge of the acromion in case of a chronic tear. Because since there is already any signs of impingement there, I might end up doing an acromioplasty in this case. So usually I do it at the end of the procedure. So I just clearing it. So already I have seen the anterior and the posterior edge. Now I am going to see the lateral edge of my acromion. So below is the cuff. The cuff tissue looks fine for a chronic tear. Those are the bursal tissues. So these are the bursal tissue. If you have a good anesthetist, then I don't mind in taking out with a shaver. But if the anesthetist is one of our secondary PGs or somebody, then we have to go on. We should understand the situation and deal with it. Otherwise, once it starts bleeding, then always you will struggle and start, cursing others in the theater. So this is we are going in. I am preparing the posterior part. So you have to see the cuff entirely, the anteriorly, middle, and the posterior part of the toned retracted cuff. So this is actually the posterior end of the cuff. So that area should be clear. Already this is a prepared footprint. So again, I am trying to get the lateral edge. So this is the lateral edge of the acromion. So you can see now that's the lateral edge is also properly. That's the anterior edge. That's lateral edge. Some bursal tissue is left there. So I've got I think that's a shaver in. So I'm trying to remove with a shaver some amount of bursal. See the bleeding, it has come. I'm trying to cauterize it with the RF. So when you are using a shaver, just shave it, then stop it, then use a cautery and go. Just don't go and use the shaver around and try to finish it off, because then you will have a lot of bleeding and you may not be able to find out. So some kind of frayed tissue again on the side. So fully try to clear the acromion. See the edges again I am trying to clear. So this is the RF again going. So in a shoulder arthroscopy in a cuff tear, you cannot do. This is the entire picture. This is something like a U-tear, and I am using a grasper and it's a suture retriever, and trying to pull it and see whether the cuff is coming and whether release is adequate. So it is already coming into the footprint without any abduction. So the release is adequate. That means I can understand that I can go in for an anchor placement. So if it is not coming to the footprint, your cuff after release, then you have to think about either going further release, or you have to think about medializing your footprint. So this is it's not a very big tear. So I generally use, if it is a little bigger tear, I use 2 medial row anchors. This is somewise a mid-sized tear, and it's a economically challenged patient. I thought of putting a triple loaded medial anchor. So I actually thought this is I use a mattress stitch. So this will be 1 stitch, 2, 3, 4, 5, and 6. So I thought that will hold if you have a triple loaded. So this is a triple loaded anchor. which I put medially. When you are triple loaded anchor, the issue is of entanglement will be there because a lot of threads are there and you are trying to put a mattress stitch. You can use otherwise when you are using an all, because I generally use all switchers anchors fully, but the issue in using an all switcher anchor, you cannot have the leverage. If you put a all switcher anchor here, when I am tightening one of them, it will pull out. So you have to have an anchor which is having a good hold when you are trying to use a single medial anchor. So this is a triple loaded medial anchor that is being screwed in. So that will be put somewhere in the middle of the your footprint, somewhere just middle to it. So you can see there is a blue tiger, a black tiger, and a green. So that is there, that's the anterior part. So we will go one here, one somewhere here, one somewhere, and two posterior. So we will use the suture passer. You can use whatever suture passer system. I still remember when I started doing shoulders, we used to have bird beak and lassos to do the cuffs, and then came the like the elite pass where you have to then retrieve it. Now everything is so simple. Orthopedics is always advancing. So this is the suture device. You have to just pass it in, and that will automatically take the thread also. Earlier it was you have to push it in, use a bird beak or a lasso, then shift it, or you have to use, then the first generation of this kind of a suture passer was, you just put it, the thread will be there, then you have to use a suture retriever and take it out. So that has changed. So I think slowly, orthopedics will go for an engineering revolution, and everything is getting simplified for the surgeon. So this is the anterior two threads passed. That's the black tiger. So anteriorly I have passed two. So then I will have the middle one. So here I am trying to pull it, so it's coming to the footprint. So that's okay. Then you should be able to see your entire cuff tear. Without that, you don't start passing your threads. So passing anteriorly and middle is easier. Once it comes to posteriorly, it becomes difficult until you don't shift your scope. So here my entire viewing portal is posteriorly. I have not changed my portal at all. And this is the middle one. So again, when you are trying to pass your suture passer, you try to maneuver it such a that it is not going underneath the one you have passed. Otherwise, it will get entangled. So, so anterior ones, I think, if I remember in this case, I could manage, but the posterior, I got it entangled. I unwinded it. I think that will be seen. So this is the two middle one. So the middle cuff. You can see the other one there. So the two middle. So to identify it, I have put the black tiger in the front, the green in the middle, and the blue tiger posteriorly. So it is easier to identify where to go, because I am planning for only a single lateral row anchor. So I wanted to know which threads and what. So otherwise I will be confused. So I am not using two lateral row anchors. So here, so see, this is the part when it comes to posteriorly. Your trouble. You have to go slowly. See, I am going underneath the other threads so that it won't entangle. If you go overly, then it gets entangled and you have to unwind. So basically when you are using these triple loaded, entanglement of the thread is a big issue. So opening of the cuff is also a problem. When there is a chronic tear, there will be little elevation. So you should ask your assistant to pull your shoulder down so that you will get little bit space. So here I asked my assistant to pull the humeral head down so that I get better space so that I can open my first pass and go in. So that was a misfire. So I am going for the passage. This is the posterior one. So I got that. So we got these threads. So now we will look around whether there is an entanglement or not. So you look around, there is an entanglement. If you look very closely, you can see there is an entanglement of the thread there. This is not like the others. So there is an entanglement. You try to pull it, see, that is entangled. So you have to unwind it. So you use a suture retriever. Be careful when you are trying to unwind. Always try to unwind it, because otherwise once you have put the knot, then it is difficult. You can pass it again, it doesn't matter. It may take another 5 minutes more. So that is again unwinded. So there is another thread which is going underneath. So there is again, you can see there is an entanglement. Another problem, since I don't use cannulas, another thing is that it can get entangled into soft tissue laterally on the portal. So that also has to be cleared. So this you can see, that is you have got 6 threads now onto the cuff. So the 6 threads is there. This is the entire thread. There is one here also, and you can see that's the one. There is another one here. So you have got the 6 threads. So this is a mattress type of stitching medially. Some people like to just put it and put a lateral row. I like to put the knot in my medial row also. So you'll start with I always like to put the, like when I am doing my usually we use 2 double row, 2 middle rows. So I put the middle 2 first, then the anterior and the posterior. That's how I go. Since I think I put the middle one in this, I don't remember. So sorry, I didn't see the video before that. So if I see here, there is an, it's one of the thread is entangled in the soft tissue. So I have to release it. Yeah, I am putting the middle one. Middle one is the blue, so the green one. So I put the middle ones, and I asked my assistants to pull the other 2 threads. So the middle one is the knotted first. The middle one is knotted first. Then I will go for the posterior one and then the anterior one. So that's a middle one which is threaded. Yeah. So the middle knot has come. So again, there will be some kind of, bleeding, some kind of bursal tissues coming and entangling. So that is the anterior one, the anterior knot coming in. The middle knot we have done. Now the anterior one we have done. So we'll go and put the posterior knot next. So you have your assistant holding your scope, and when you are doing threading. So it's always a challenge that you should have a good assistant. So once your fellows are new, it's not that every time you will be getting a good picture. So this is the posterior knot which is coming in. So once you have put that's a posterior one. The posterior knot coming in. So the posterior knot. So we have all the 3 knots in. So posterior and so in this case, then I had a relook. If I remember, I used the posterior and the middle one, because we can pass only 4 threads to your lateral anchor. So I cut the anterior out and use the middle and the posterior. So this is the one when we have put the your medial anchor. The defect is completely covered, but the footprint is not fully covered. So that is the issue of using a single row. See the footprint, we had put the anchor here. The anchor is, we cannot see the anchor hole now. That's the anchor. So that is covered till that area, it is covered. So now I am going to go laterally. So that is the lateral part of the GT. So that is the lateral part of the GT. I use an RF. I ask my assistant to abduct and hold, and I clear that area because I want to put my second lateral row anchor here. Then only I will get the maximum excursion to pull it. So this area has been prepared. So that's Again, there is tissue. I wanted at least 3/4 of my footprint covered. Um, so that is the laterally. So the lateral anchor basically, there are 2-3 companies which is coming. So certain companies, when you mallet in and tighten it, it rotates. Certain one you have just malleting in. So I don't want to name the company. This particular implant I had used was of the thing where you have to just hammer it. Even if you rotate, it doesn't come in. So this is again, we have to have a nice preparation of your lateral GT, the lateral aspect of the GT. So there will be bleeding because you are directly there. You have to cauterize. You have to have a good visualization so that area is cleared. So now I am going for a pilot hold. See, I don't even mallet. You have to always try to push it in. This particular type of implant you have to go. Otherwise, most of them you don't require now. You can just mallet it in. And the 4 threads are passed into the lateral row anchor. And we have to have your vision carefully about your lateral row when you are coming in. And since we are not using any cannulas, you should be very careful that all the threads and your lateral row anchor is coming through the same gap. It's not entangling into the soft tissue. That we have to be careful. So yeah, so that's all the threads are in the same hole. It's not going through different soft tissue area. So that's the thing. Then you have your anchor getting loaded. That's the time. I will be loading the anchor outside. So outside picture is not there. It's only the inside picture. You pass 2 threads through their lateral row anchor. Yeah. So many minutes. Okay. So it's as I told you, it's totally it's actually almost an unedited video. So sorry for little bit delay here and there. So this is the anchor which is coming in. That's the lateral row anchor. You got it in. You see that all your threads are going into that, and it is, you rotate and you have to see it is not entangling, and it is getting in. Then you ask your assistant to pull it and hold each thread and hold it, then mallet it in. So that is getting malleted. So that in the end, that's the lateral row anchor going in. Then there is a mark, you should be careful, the mark is done. So you can see where was the thread earlier and now where is the thread. So it is almost completely covered your footprint. So but again, if you look at it, the space here is less as we have anticipated earlier. There is acromia, there is a space is like here hardly like 1 or 2 millimeters only of footprint left, otherwise entire thing is covered. So we have to go for a acromioplasty in this patient. So again we come, this is the cuff which has completely covered the footprint. So I am that's a knots which has come in. So this is a burr, acromioplasty you have to do. Since I have already used an RF and planned how much I have to do my acromioplasty, I generally try to make it burr. If you look at the acromion, there is a slight curve once you debride it. So I wanted to get it level with the inside and the outside. There is a small curve like that, you can see that. So I take about 2 to 3 millimeter of bone. You have to use a burr nicely and cover it up. So that's a burr being used. So we are almost there finishing. So the burr, when you are using the burr, again you should be careful. Don't put your suction in. If your suction should be on the just slight on, don't put it fully, then all the soft tissue will come in. So that's that. Thank you.